we're happy. Good afternoon, everybody. We hope that we have an interesting dialogue today about fertility preservation. And I'm very pleased that Dr. Susan Maxwell, who is our newest partner from NYU, who is running our Santa Barbara facility, is going to be joining us to give us a little bit of insight as to why this is important to do and how the technology works. And then we'll finish up with some facts about the technology that we'll go through, as well as expected results and outcomes. And then we'll have time, I think, for some questions and answers when we're finished. So, Susan, would you like to get started?
Okay. Well, thank you for joining us. We're going to talk about fertility preservation today, and I'm joined by Dr. Mark Surrey, who is one of the founders of Southern California Reproductive Center. He is a leader in the field of reproductive endocrinology and infertility, as well as in reproductive surgery and in vitro fertilization. He is a clinical professor in the Department of Obstetrics and Gynecology at the David Geffen School of Medicine. And he just has a wealth of knowledge and experience in the field, and we're very lucky to have him be a part of this practice. Next slide.
Thank you, Susan. We're lucky to have you too. So,
yeah.
Want to get started, Susan? Let us know what we should learn about this field.
Yeah, so my name is Dr. Susan Maxwell. I work out of our Santa Barbara office. I completed my training in New York at NYU School of Medicine, and I worked in New York City for about 5 years before moving to California and working with Southern California Reproductive Center in Santa Barbara. Next slide. At SCRC, we have a proven track record with more than 25 years of experience. We are proud of our 2 state-of-the-art embryology labs. Our flagship location is in Beverly Hills, and we have a smaller laboratory in Santa Barbara. Both locations have on-site surgery centers. We also have monitoring available in Pasadena as well as Ventura. What really sets us apart with our premier laboratory and surgery centers is that we have the latest technology in both locations. We have experienced and certified laboratory directors. We perform double witnessing verification on all samples to make sure the right gametes are being used for the right patient. We perform vitrification, which is a flash freezing technique, which has improved outcomes for egg, sperm, and embryo freezing. And we have a lot of experience with embryo biopsy techniques. We do a lot of biopsies for genetic testing for aneuploidy, which is PGTA, as well as looking for monogenic disorders, which is PGTM. And we can look at all 24 chromosomes now in the embryo, as well as perform sex selection if desired. We also have embryoscopes available in both locations, and an embryoscope is time-lapse video analysis of embryo development. So we don't have to touch the embryos as they're developing. We can look at the images of their progression and development, and this helps us select the best embryo for transfer. Next slide. Today, we will be discussing age-related decline in fertility, what is the age factor, and how to optimize your cycle, and who is a candidate for fertility preservation. And then we'll go in detail over the egg freezing process and end with a question and answer session. Okay, next slide. So what does it mean by the age factor? Well, it means that as women get older, the chance of getting pregnant or conceiving per month goes down. And we attribute this to the fact that the percentage of normal eggs that a woman has, or eggs that are able to produce a genetically normal embryo when fertilized, goes down with age. So in women who are under 35 years old, we see that about 50% of embryos are genetically normal. At 38 years old, it's about a third are genetically normal. At 40, it's 20%, and then at 41 plus, it drops down to 10% or less. Next slide. And the reason for this is women are born with all of the eggs they'll ever have. And over their lifetime and with each menstrual cycle, they lose hundreds of eggs. So by the time a woman goes through menopause, most of the eggs have been depleted from the ovaries. And as these eggs get depleted, their quality declines. We don't know the exact reason for this, but it could be due to lifetime exposure to free radicals or other toxins, or just the aging process in general. Next slide. When we see somebody who is interested in fertility preservation, we do an initial evaluation. We take a detailed medical history, and then we perform a physical exam and do some diagnostic testing. Next slide. It's important for us to assess your ovarian reserve, and we look at different markers to give us a sense of how many eggs are in the ovaries. We start with blood tests. So there's a test called an AMH, an anti-Müllerian hormone. And this is a marker of the total number of eggs in the ovaries. AMH does go down with age, and this is because the egg numbers are declining with age. We look at FSH, which is follicle stimulating hormone, as well as we do a pelvic ultrasound, and we look at the antral follicles, which are the resting eggs on the ovary that month. And the antral follicles give us a sense of the total egg reserve as well. Next slide. For men undergoing fertility preservation or for fertility treatments, we recommend doing a semen analysis. And we look at four main components of the semen analysis. One is volume of the sample. The other is concentration of the sample, or how many sperm are in the sample. Then we look at the motility, and normal motility is around 50% or higher. And then morphology, which is the way the sperm are shaped. Next slide. For patients undergoing fertility preservation, we believe in a holistic approach. There are many factors that can contribute to your fertility, including nutrition, other lifestyle factors such as exercise, stress levels, and other treatments such as acupuncture, meditation, exercise can really help to modulate those stress levels and improve outcomes. Next slide. Benefits of nutrition for fertility. Certain vitamins and nutrients are linked to positive effects on fertility. We encourage healthy diets such as a Mediterranean diet with plant-based foods, such as whole grains, vegetables, legumes, fruits, nuts, and seeds. I think the key term here is plant-based and avoiding processed foods, which are low in nutritional value and can contain more chemicals that are just overall not good for your health. Folic acid is a supplement that is good for fertility. It can be found in dark leafy green vegetables, asparagus, or legumes. Vitamin B12 is good. It's found in organ meats, as well as omega-3 fatty acids, which are in fish. In general, we recommend that patients take a multivitamin or a prenatal vitamin to help supplement some of these during their cycle. Next slide. Other supplements that are beneficial for fertility are CoQ10, and this is a potent antioxidant. So all antioxidants have been shown to be beneficial for fertility, and those can be found in certain fruits and vegetables, green tea, but CoQ10 is a great way to boost your antioxidant levels. Vitamin D is also helpful and has been shown to improve fertility and decrease miscarriage rates. Next slide. There can be several benefits to acupuncture. It improves sleep, reduces stress, and improves blood flow to the pelvic organs. Patients find that it really helps them manage their stress as they're going through different hormonal treatments. Next slide. We recommend avoiding toxins during your cycle, including alcohol. So high alcohol consumption around the time of ovulation is really toxic to the egg. And so abstaining from alcohol during your cycle and reducing it prior to your cycle is very helpful. Cannabis is associated with fewer eggs retrieved and lower percent fertilized. Cannabis use in men has a negative impact on sperm. We see lower sperm counts and lower motility with chronic cannabis use. And tobacco is also can be harmful with reduced AMH levels and antral follicle counts, decreased IVF success and live birth rates, and increased pregnancy loss. Next slide. And now Dr. Surrey will talk a little bit more about the egg freezing or fertility preservation process. Next slide. Dr. Surrey, you're muted.
Can you hear me now?
Yes.
So I was taken by your suggestion about plant-based diet, and I guess that means we gotta stop bacon cheeseburgers. Anyway, what I wanted to do is get back to one of your earlier slides that I think is relevant to our discussion, and it's really the point of it. And it has to do with some graphs that you show about monthly fecundity rates going down significantly, so much so is that the average person's fertility rate at 40 is a fraction of what it was at 30. And this is not something that's related to your diet, but rather to your chronologic age and the way in which the genetic content of the embryo that your egg will create develops. And there's a significant change that we see with that as we age as human beings. So the rationale for freezing eggs, and people ask, well, when do I need to do that? Can I wait until I'm 40? Maybe not. Should I do it when I'm 30? Maybe so. So there is a significant change in egg production as well as the quality of the eggs as we age as human beings, which is the reason for our discussion today, really. Next slide, please. So what we're going to chat a little bit about is how this comes about. And it does so by stimulating the ovaries to make more eggs, because as Dr. Maxwell has shown us, a lot of the eggs that we produce are not going to create a normal pregnancy. And you don't really know the way in which the egg will create a pregnancy until such time as you choose to fertilize the egg, which does not have to be when you produce the egg. You can produce eggs, and then at your convenience and when it's socially and emotionally appropriate for you, we then can fertilize the eggs, thereby creating embryos. And as Dr. Maxwell suggested, it is the embryo that will show you the likelihood of the egg causing a pregnancy. So this is something that we do clearly understand. So producing more eggs is the basis upon which this technology is effective for us. And when we do that, it's done with a combination of natural releasing factors that come from the anterior pituitary gland that are FSH, or follicle stimulating hormone, and LH, or luteinizing hormone. And we take that on a daily basis, and it's given underneath the skin. So when you think about the fact that people well, I have to take shots, those are the shots. They're similar to what people with diabetes take. It's a very small insulin kind of a syringe that the majority of people are fine doing themselves because it's more convenient that way. The average number of days that you take this for is around 10 or 11, during which time we need you available to do monitoring, which is performed with ultrasound imaging and hormone levels to see the response that you have to these stimulants and when you're ready to have the eggs retrieved. Next. This is a little bit what an ultrasound would look like on day 1 and on days 10 to 14 and on the day of the retrieval. And what you'll see on the ultrasound are these circles that represent fluid in follicles that can contain eggs. On the day of the retrieval, this fluid is aspirated by ultrasound and evaluated in the laboratory to make certain that a normal appearing egg is retrieved. Next. So once eggs have been harvested, they can either be fertilized at that time or preserved in an unfertilized state. And it is this unfertilized state that exists in the laboratory, and the eggs are going to be the same in a few years as they are when you produce them. So that's the key to this technology, is something called vitrification, which is the way in which we preserve human tissue. Next. So its preservation is very effective. The thaw survival is well into the 90th percentile. Fertilization and cleavage rates are the majority of those. And then implantation rates, the difference between this and this has to do with a number of different factors, to include the genetic content and analysis of the embryos. Because if an embryo is not genetically normal enough to cause a normal pregnancy, then we don't implant it. So there have been lots of babies born with this technology without any issues being noted. And what we see is that the clinical pregnancy rates are going to always be a fraction of the rates of the fertilization of the eggs that are preserved. And that's because of a lot of the eggs that are preserved will not divide normally. And of the ones that do divide normally, many of those may not be genetically normal, which is the reason why you're given stimulants to make more. Next. So most people find that this process is one that allows them to return to their normal activities within a few days. Heavy exercise is usually suggested to hold off on for a few days, and we like to follow our patients after their retrieval. So we like you to plan to be available for a checkup afterwards. Next. So when should you consider fertility preservation? Well, whenever you're thinking about it, because if you look at chronological age for that, what we've seen is somewhere in the early 30s is the most appropriate time, but it's certainly not harmful to do so a little earlier. They can stay frozen for many years, and you find out how many eggs will be frozen at the time, but your doctor should discuss with you the monitoring results of your cycle and how you're doing. As to whether you should or could do multiple cycles of egg freezing will depend upon what you have in the first cycle and what your goals are. So, for example, if you're 30 and you have 10 to 12 eggs, we like to think that should be sufficient for a single pregnancy. So if you're 30 and you want to have 2 pregnancies, then you may want to have twice that number, and that may involve doing more than 1 cycle. So we find out the answer to these questions frequently by doing the process. Next. So there are some promotional events that will occur both in the different locations in Beverly Hills and as well as Santa Barbara. I think the next one is coming up next month with free AMH testing and consults about the results, which is going to be, I believe, in the Beverly Hills office. And Dr. Maxwell, I think, may have something similar sometime this fall in Santa Barbara as well. Next. So this is the team of physicians, and Dr. Maxwell is primarily in charge of the Santa Barbara location. Dr. Chavkin is primarily going to be in both Beverly Hills and Pasadena, and Dr. Alexander in Beverly Hills, Dr. Danzer in Beverly Hills, and myself occasionally also in Santa Barbara. So we will look forward to meeting any of you who are interested in discussing this issue. Next. And if you have questions that we can answer today, we're happy to do so. If there are questions you think about, please don't hesitate to inquire, and we can set up consultations either remotely or in person with anybody interested. Next. So,
yeah, so now we will be going to the chat and answering any questions you have.
okay.
So the first question is, someone's asking if they froze 21 eggs at age 36, what is the chance of success of having a baby?
You want to take that?
Yeah, so there are different charts or calculators we use to help predict the chance of success, and these are based on large studies or national data of women who have thawed their eggs. At 36, with about 20 eggs to thaw, gives you probably a 70 to 80% chance of having a successful live birth from that. So that's a very strong number to have at least 20 eggs frozen. Mm-hmm.
Yeah, that sounds great.
Mm-hmm.
So, Canadian, live in Vancouver and froze your eggs locally. We do work with a group in Vancouver, and it is possible to transfer either eggs or embryos, depending upon which group that you worked with in Vancouver. So we would need to know some details about your cycle from the group that you worked with in order to answer that question. But it is possible. And our clinic, by the way, has specialists in surrogacy screening and recruitment. So we're very supportive of the process of gestational surrogacy and find that we end up seeing a lot of people from other parts of the world where this is not legally possible. And so it's something that we have a fair amount of experience with. Susan, do you want to take the next question, perhaps?
Yeah. So the next question is, what are the first treatments that we employ before moving to IVF? So when we're evaluating a patient with infertility, we do a series of tests to look for all different causes of infertility. And if we do find something in particular that is wrong, then we go ahead and treat that, whether that's thyroid disease or if there's a problem with the uterus. Sometimes we do surgery to help optimize the cavity. Other treatments that come before IVF are what's called ovulation induction, and that involves taking an oral medication for 5 days at the beginning of your menstrual cycle, and then we do monitoring ultrasounds to watch for follicle progression. We trigger ovulation and then help either time intercourse, or we do something called an IUI, an intrauterine insemination. The pregnancy rates are a lot lower with natural pregnancy or ovulation induction than with IVF. So it's always a discussion between the physician and the patient which treatment is better to start with.
So just to amplify your answer to that question, a lot of people have the idea that IUI or intrauterine insemination is a variation of IVF, and it's actually not. An IUI is an indication that there is normal fertilization and embryo development that occurs in the fallopian tube naturally. So IUI is sort of a natural conception. So there are relatively few indications for that, and the results of that are not going to be nearly as good as the results of IVF because you don't have a chance to observe or influence embryo development. So you don't really know about it. But anyway, so that's just a thought about IUI. Susan, there's a patient traveling from Mexico, wants to know how many days she's got to be around to preserve her fertility. You want to answer?
So the treatment cycle takes about 14 days from starting medications until having your procedure, and we do want you to be around for ultrasounds and blood work during that period of time. And then we recommend that you stick around for several days after the procedure to make sure you're recovering and you're feeling well before you travel. So depending on how stimulated you are, how many symptoms you have, we might want you to stay for 3 days after, or it could be longer, 5 or 6 days after your procedure before we clear you for travel.
Very good. We do see patients from Mexico. There are some clinics in Mexico with whom we work for screening testing. So if you let us know where in Mexico you're traveling from, we can see if we can work with one of the local clinics for you to minimize the time that you need to be away from your home. So let's see, there's a question apart from AMH and I guess it should be FSH.
Just age. Mhm.
What are some other markers that we'd like to focus on in regard to conception? Well, there are a lot of different markers, and there are a lot of different types of assessments that we like to do, including an ultrasound image of the reproductive system. So I think that the best answer to that question is it depends upon who we're talking about. And in order to know that, we like to see you either in person or be able to have a remote consultation to get your individual medical history to see what tests might be best for you to do. It's a little difficult to know that without being able to get more information about you as an individual. Susan, did you have any other thoughts about that?
Well, I think when we see a patient initially, there are a series of tests that we do to look at all aspects of fertility. So we're looking at different hormones, we're checking the ovarian reserve, we're checking the thyroid, we look at a hormone called prolactin, which can affect cycles. We do the pelvic ultrasound to look visually at the uterus and ovaries. We often order a test called an HSG, a hysterosalpingogram, which is a dye test done at a radiology department where they put a catheter in the uterus and they put some fluid inside, and the fluid highlights the inside of the cavity, and it also goes through the tubes to make sure that the tubes are open. And then we do the male testing, semen analysis. And we look at the whole picture before deciding what treatment is necessary.
So I don't know if anybody else has any specific questions, but we're available and happy to chat with you guys individually at any time, perhaps with some privacy, by having you call any of us at any of the offices. So it's been a pleasure to spend a little time with you this afternoon, and we hope that it's been informative for you to be with us. Susan, any other thoughts?
No, we'd be happy to meet with you individually and go over your case and come up with a customized treatment plan for you. Mhm. Mhm.
So everybody have a good evening and be
Mhm.
careful, and we'll look forward to hearing from you if you have any questions. Take care.
Thank you. Mhm.